Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, everyone. Okay, I'm going to talk about the bones of the lower limb. Okay, the bones of the lower limb can be divided into two. Number one is pelvic girdle, and number two is free lower limb. So pelvic girdle consists of these three bones, okay, the sacrum, coccyx, and also hip bone. But in this lecture, I will going to talk about just hip bone, because sacrum and coccyx is under the spine. So I'm going to talk about this later in my lecture, anatomy of spine. So today, we'll talk about the hip bone. Okay, hip bone consists of ilium, ischium, and pubis. And while for free lower limb, there are femur, tibia, fibula, patella, tarsal, metatarsals, and phalanges. Okay. Okay, this is pelvic girdle. Okay, this is pelvic girdle. Okay. It's made of two hip bones. So this is hip bone 1, hip bone 2. So it is made of two hip bones, all right? Okay, it is connected posteriorly by the sacrum. So this is sacrum and coccyx. So this is sacrum and this is coccyx. This is the last two spine vertebra. Okay, and then it is connected anteriorly by the structure called anterior pubic symphysis. Pubic symphysis. So it is a ring. Okay, it's a girdle that we call this pelvic girdle. Okay, consists of two hip bones, the right and the left hip bones, which connected anteriorly by the pubic symphysis and posteriorly by the sacrum and coccyx. All right. What is the function of the pelvic girdle? Is actually connecting the trunk, the body, to the lower limbs. Okay. Okay, let's move to the hip bone. Okay, hip bone consists of ilium, ischium, and pubic. So the superior part is ilium, and inferior, anterior is pubic, anterior, posterior is sacrum. So this is the medial view. How you know this is medial view? Because you can see there is this surface where we call this auricular surface for articulation with the sacrum. So this is the medial view of the hip bone. This is a hip bone that made of ilium, superior and inferiorly. It has two pubic bone at anterior and ischium at it posterior, inferior. Okay, this is how it look in pediatric patient, where you can see these three bones are not fully unite yet. Okay, you can see the upper part is sacrum. Okay, this is sacrum, and this is pubis. Okay, and this is ischium. So pubis is slightly smaller than the ischium. Ischium is bigger than the pubis, and ilium is easily identified in this X-ray. When will this the hip bone in pediatrics is not yet fused? Okay, they will fuse at about 11 to 15 years old. Okay. Okay, go to the hip bone again. Okay, this is ilium. Also, this is lateral view. You can see this is ilium. Okay, and this is ischium and this is pubic. So pubic is anterior, ischium is posterior, and this is ilium. Okay, how do you know this one is lateral? It is by the presence of this one. Okay, this is acetabulum. Okay, this is acetabulum. Okay, this acetabulum is now socket for the head of femur. So that means head of femur will articulate at this space called acetabulum. So this acetabulum originally is really, really shallow. So it is it actually not really fit for articulating with the head of femur, but with the presence of a structure called labrum. Labrum is a connective tissue, a tough connective tissue. The acetabulum will be more deepened. Okay, so the head of femur can fit to this acetabulum very well and stable. Okay. Okay, this is the acetabulum articular surface. Articular surface. Okay, where the head of femur is actually articulate here. This is what we call a lunate surface. Lunate mean moon. Lunate of acetabulum, and this is non-articular surface of acetabular, or it is known as acetabular fossa. Okay. Okay, down here there is an opening called obturator foramen. So this is obturator foramen. Okay, it is located in between the two rami of pubic bone and also ischium. So the ramus of ischium and the rami of pubic bone is surrounding the obturator foramen. Okay, the obturator foramen is actually covered by the structure called obturator membrane. Okay, so this foramen is actually closed foramen, and it is covered by the obturator membrane, except at this region where the obturator groove is present at the pubic bone. Okay, this is the obturator groove. Okay, at this region, it is not covered by the obturator membrane, and obturator vessels and nerve is passing through this obturator canal. Okay, this once the obturator foramen is closed or covered by the obturator membrane, this area will left open, that we call it obturator canal. Okay. Okay, now we go to the ileum in detail. Yeah, this is ileum. It is the superior and the largest part of the hip bone. It consists of body. So this is body, and this is ala or wing. Okay, ala or wing. Okay, the body, this part is a part of ileum that fuse with pubic and ischium. Okay, and ileum forms superior part of the acetabulum. Okay. And the structure that you have to know in ileum, in ileum is the iliac crest. This is the iliac crest. Up here is the iliac crest. Okay, iliac crest form the superior border of the ileum of the hip bone. Okay, superior border of hip bone. Okay, this is iliac crest. Okay, at the anterior end of iliac crest, there is anterior superior iliac spine, ASIS. So at this tubercle is known as anterior superior iliac spine. Okay, and posteriorly, okay, posteriorly at the posterior end of the iliac crest, there is structure called posterior superior iliac spine. Okay, and then below the anterior superior iliac spine, okay, this structure, this structure is called an anterior inferior iliac spine, AIIS, and posteriorly below the PSIS, there is posterior inferior iliac spine, PIIS. Okay, these spines that provide points for attachment of muscles. Okay. Okay, posterior in PIIS, posterior inferior iliac spine, there is a structure called greater sciatic notch. Okay, this is greater sciatic notch. Okay, this is greater sciatic notch. Okay, back to this slide. Okay, when a ligament is connecting this part to this part, they will form two foramen. Okay, two foramen. This will become the greater sciatic foramen, and here will become lesser sciatic foramen. Okay. Okay, this is what I told you just now. Okay, this is obturator foramen, which is covered by this obturator membrane, and at the obturator groove here, there is obturator canal that passing through all the obturator vessels and nerve. Okay. All right. Back to ileum. Okay, the medial side of the ileum, you have this structure called iliac fossa. This is iliac fossa. This is iliac fossa. The iliac fossa extend from the iliac crest up here up until the arcuate line down here. So this is arcuate line. Okay. So what is the importance of, what is the significance of iliac fossa? It is actually the site for muscle attachment for the iliacus muscle, And posteriorly, there is auricular surface. This surface is called auricular surface, where it provides the attachment of the sacrum. Remember the sacrum that form the connecting the right and the left hip at the posterior part. Okay, so this articulation form sacroiliac joint. Okay, the surface is called auricular surface. It is the articular surface articulate with the sacrum of the spine. Okay, and the iliacus muscle is attached at the iliac fossa. Okay. Posteriorly. So this is the posteriorly or the lateral view. So this is medial and this is lateral side of it. There are three gluteal lines. So the three posterior gluteal lines, anterior gluteal lines, and also inferior gluteal lines. Okay, all these three lines are the site of attachment of the gluteal muscles. Okay. Okay, inferior and posterior part of the hip bone is formed by the ischium. Okay, this is ischium. This is the posterior part. This is ischial spine, and this is the ramus. Okay, ramus. This is the ramus of the ischium. Okay, and down here, the rough surface of the ischium is called ischial tuberosity. Okay. Do you know when we sit like this, when a person sitting, the ischial tuberosity is actually in contact with the surface of where that person sits. So the ischial tuberosity is really tough bone, okay, because it transmits the body weight from the body when it's bare the body weight doing in sitting position. So it must be rough and a strong bone. Okay, it is weight bearing bone doing when we sitting in this position. Okay, the ischial tuberosity. All right. Okay. Again, this is the pubic, the third bones that form the hip bone. Okay, it has the body here. Body is part of the acetabulum, and also the rami. Why we call it rami? Because it has superior and inferior rami of the pubic bone. Okay, If it is 1, it's ramus. If it is 2, then it is rami. So superior and inferior rami of the pubic bone. Okay, here on the medial surface, there is a symphysial surface for fusion of the pubic symphysis. Remember, the pelvic girdle, and anteriorly it is connected by the pubic symphysis or symphysis pubic. It's the same thing. Okay. Okay, again, still at the pubic bone. Okay, this is pubic bone. Okay, this is pubic crest. Anterior here is pubic crest, and this is pubic tubercle. The pubic tubercle. Oops, sorry. All right. The pubic tubercle provide attachment for inguinal ring and ligament. So attachment of the inguinal ring and ligament is at the pubic tubercle. So this is the inguinal ligament. The inguinal ligament is attached at the pubic tubercle, and this is the inguinal ring. Which part of the inguinal ring? It is the superficial part of the inguinal ring. Okay. Okay. Yeah, I actually attached this picture along in this ellipse. So actually, I want you guys to like label different parts of hip bone. Okay, that indicate the important parts of hip bone. Okay, the iliac crest, the auricular surface. You have this symphysial surface. Okay, iliac fossa, and all the structure that I have explained to you in previous slides. Okay, I forgot to brief you before this lecture. Okay, so I want you to print, or you can just draw using your tablet or laptop. Yeah, labeling. This is for your labeling exercise. All right. Okay. Okay. Finish about the pelvic girdle. Now we go to the free lower limb. Okay. Free lower limb consists of these 3 parts. Okay. Thigh. Okay. For thigh we have femur, and for leg we have tibia and fibula, and actually one more bone which is called patella. It is one type of bone, but it is actually part of the knee joint. But well, it's still a bone of the lower limb, so I will put it here. And then for foot, it is made of tarsals, metatarsal, and phalanges. Okay, let's move to the thigh. Okay, I know you know it is made of, the thigh bone is called femur. Okay, this is femur. It is the longest, the heaviest, and the strongest bone in the body. Okay. It has proximal end up here, the proximal end up here, and this is the shaft, and this is distal end. All right, the proximal end articulate with the hip bone, okay, specifically at the acetabulum. Remember, on the lateral side of the hip bone, there is the articulation surface of fossa called the acetabulum. So this acetabulum will articulate with the head of the femur. And then it has shaft. Shaft is in the middle between the proximal and distal end. And while for the distal end, it is articulating with the tibia and also with patella to form the knee joint. Okay. Okay. You can make your labeling exercise now, because this part is really important for you. Okay. The proximal end of the femur. What are all the structure that present in this proximal end? Okay. This is anterior view of the proximal end, and this is the posterior view. How do you know this? Which one is anterior? Which one is posterior? It is by the identification of the structure called this one. So this are the structure. This is what we call trochanthus. Okay, the trochanthus. So first you have to identify the trochanthus. So the trochanthus are present at its posterior side of the femur. Okay, so once you identify the trochanthus, then you know that femur is belong to the right or the left leg. All right. Okay, so this is the trochanthus. Okay, it has. So before we go into details about the trochanthus, so this is the head of the femur. You have to know this is the head of the femur, and this is the neck of the femur. The head, and this is neck, and these are all the trochanter. This is called the greater trochanter, and this is lesser trochanter. Okay, the greater and the lesser trochanter. You don't get confused with the femur. The humerus. The humerus. There are also this kind of structure, but in humerus it is called tubercle. So for the femur it is called trochanter. So this is greater and this is lesser trochanter. So in between, anteriorly, in between two trochanter, the greater and lesser trochanter, there is intertrochanteric line. This is what I call intertrochanteric line. So why does it call line? Because there is it's just actually imaginary line. Okay, it's not really a line here, but it is just imaginary line. The line located between the greater and the lesser trochanter. Okay, posteriorly, it is also intertrochanteric crest. Okay, posterior it has crest. Okay, intertrochanteric crest, because actually the crest is more prominent. Okay, and rather than the line is just imaginary, and the crest is more prominent. So it is actually slightly elevated. Okay, in between the greater and the lesser trochanthus. Okay, what are there in the head of the femur? Okay, there is the fovea or pit. Okay, pit or fovea. This one, number 7. In this picture is number 7. It's provide attachment for the ligament of head of femur, or the name of the ligament is also known as the ligamentum teres. Ligamentum teres. Okay, there are many ligamentum teres in our body. Okay, you can actually identify more than one. Okay, ligamentum teres in our body. One of it is that attached to the head of the femur, specifically at the fovea or pit of the head of the femur. Okay. Okay, the proximal end. This is some clinical facts, a clinical correlation. So the angle of inclination of a neck of femur and the shaft is approximately at 125 degree. Okay, but in the case of when the degree is lesser than 125, like for instance is 105, this is what we call a coxa vara. Okay, where the angle is diminished. Okay, this is coxa vara, and in the case of increase of this angle of inclination, like for in this picture is 140 degree, this is called coxa valga. Vara reduce, valga increase. Okay, vara is lesser than valga. Forwards and valga is 5. So valga is more and vara is small. So vara and valga. Okay, this can be due to many conditions. One of them, for in coxa valga, it is happen in cerebral palsy baby, and coxa vara can due to any pathological condition. Okay, this is really important clinically. Okay, the blood supply to the head and neck of femur. Okay, blood supply to the head and neck of femur. Okay, for the most important are the medial. This is the medial and the lateral circumflex femoral artery, medial and lateral femoral circumflex artery. And there is the ligamentum, artery of ligamentum teres, remember, ligamentum teres that attach to the fovea of the head of the femur. So there is an artery called the acetabular branch that arises from the obturator artery. Okay, and number 3 is minor contribution of superior and inferior gluteal arteries. Okay, not in this picture. Okay, repeat again. Medial and lateral circumflex femoral artery, and also acetabular branch of obturator artery. Okay, it's located actually in within the ligamentum teres. Okay, this is the obturator artery that involved in the blood supply of the head and neck of femur. Which part of it? The acetabular branch of the obturator artery. Remember our obturator canal that passing through all the obturative vessels. Okay. Okay, the shaft. The second part is shaft. Okay, shaft. This is shaft of femur. Okay, it's smoothly rounded part of the femur. Okay, except at its posterior surface. Okay, remember this is the posterior surface because we actually identifying the trochanter, the greater and lesser trochanter here, and this is the posterior part of it. Okay, the posterior surface of the shaft of the femur, there is a line called the linea aspera. So this is linea aspera. So this is the medial lip, superior medial lip. Okay, inferior medial, superior medial, and this is the lateral lip of the linea aspera. So it's actually running down here, continuous down, and at the proximal part of the femur, it divides into the lateral supracondylar ridge and also medial supracondylar ridge here. Okay, lateral and medial supracondylar ridge. Actually, the arrow should be more down here. Okay, this is the lip of the linea aspera that continues down with the lateral supracondylar ridge and medial supracondylar ridge. Okay, and okay, which one is the linea aspera? Okay, this one. Okay, now we can actually identify the gluteal tuberosity. This one, gluteal tuberosity. This provide attachment for gluteus maximus muscle of the back, muscle of the gluteal region. And the pectineal line is actually this one, okay, running down from the lesser trochanter, this one. Okay, this is the pectineal line that provide attachment for the pectineus muscle. Okay. So this one, yeah. All right, okay. The distal end of femur. So down here is the distal end of femur. Okay, it has popliteal surface at the posterior part. Remember the linea aspera. Okay, below the division of the lip of the linea aspera at a surface called the popliteal surface. This is where it is located. And this is the popliteal surface. And then at medial side there is a adductor tubercle. Adductor tubercle is above the medial epicondyle. Okay, this is medial epicondyle. Okay, and then on the lateral side there is lateral epicondyle. Okay, and this is lateral condyle, and this is medial condyle. Epi means tepi lah, tepi. Okay, medial epicondyle, lateral epicondyle, and this is condyle. And in between two condyles, there is intercondylar fossa. Okay. Okay, looking at this, this is anterior and this is posterior. So anterior, The red line is actually line for attachment of the synovial joint. Synovial joint of what joint do you think? It is obviously the knee joint. So the knee joint, synovial joint of the knee joint is attached here. Okay, and this is the patellar surface. Patella. Remember the patella, one of the knee that form the one of the bone that form the knee joint. Okay, we're going into detail about this later. Okay, this is medial epicondyle. This is medial condyle. This is intercondylar fossa. This is lateral condyle and lateral epicondyle. This is popliteal surface. Okay, popliteal surface. This is medial supracondylar ridge and this is lateral supracondylar ridge. Okay, not to forget there is small tubercle called adductor. So obviously it will provide attachment for adductor muscles, adductor muscle of the thigh. Okay, we will learn this in the next lecture. Okay, these are all the important structure of distal end of femur. You have to know this. The lateral epicondyle, the medial epicondyle, adductor tubercle. Make sure to memorize the adductor tubercle is actually on located at the medial side. So above the medial epicondyle is adductor tubercle. So what is the significance of adductor tubercle? Is provide point of attachment of the adductor muscles. And then you have medial condyle and lateral condyle. And in between the medial and lateral condyle, there is intercondylar fossa. So easy, kan? So this is posterior view. You can see this one is actually popliteal surface. Okay, some clinical anatomy about the femur. Okay, this is the head of femur and this is neck. Okay, the fractures of the proximal end of femur is common. It can happen in young adult, especially due to trauma, and in elderly, in osteoporosis case. And it can be present in intracapsular. This is intracapsular, and also extracapsular. Okay, capsule in this sense is actually the capsule that form the hip joint. Okay, you will learn this later in joint lecture. Okay, the capsule of the hip joint. So this is intracapsular because the fracture is within the capsule of hip joint, and this is extracapsular because the fracture is located outside the capsule of the hip joint. Okay, which one has a better prognosis? Obviously, extracapsular. Extracapsular has better prognosis because the blood supply specifically to the head of femur is not really affected. Okay, while for intracapsular is poor prognosis, the blood supply to the head of femur is affected, and the union of fracture is difficult, and this may lead to a vascular necrosis of the head of the femur. HOF means head of femur. And this kind of fracture easily unites. Okay, this is your labeling exercise. So you have to know what are the important structures that present in femur, shaft, and also the distal and proximal part of femur. Okay, now we go to the leg. Okay, yeah, the leg. Okay, before we go to the leg, we have to. I'm going to talk about patella. Okay, what is patella? So this is patella. Actually, you can touch on patella. Okay, it's actually movable. Okay, it's movable because it is actually a sesamoid bones. Bones ni dia sorang-sorang saja. So it's embedded within the tendon of quadriceps femoris muscles. Okay, this is quadriceps femoris tendon. Okay, and down here it becomes the patellar ligament. So it is part of the knee joint. Okay, posteriorly, this is the posterior surface of the patella. You can see this is the articular surface that articulate with the distal end of femur. Okay, the function of the patella bone is to strengthen the quadriceps femoris tendon and to protect the knee joint. Okay, so each patella have a base, at its superior part and apex at its inferior part. Okay, this is the articular facets for medial and lateral condyles of the distal end of femur. Okay, now we go to the tibia. So this is the bones of the leg, which are tibia and fibula. Now we talk about tibia. Okay, tibia is the largest bone of the leg. Okay, bone of the leg. What is the largest bone in the body? It is the femur, and the strongest is also femur, and the longest is also the femur. So the second longest bone in the body is called tibia. This one, tibia. It is bare weight bone, where it bare of human weight. So the weight is transferred straight direct to the tibia. So articulation of the tibia at its proximal end is with femur up here, with femur and fibula up here. Okay, and distal end it is articulating with the fibula and talus down here. Okay. Okay, the proximal end. Okay, this is really important for you to know this. Okay, the proximal end. Okay, it has a lateral condyle. Okay, lateral condyle and medial condyle. Okay, and then how do you know which one is anterior and which one is posterior? Is by the presence of tibial tuberosity. Tibial tuberosity present at its anterior surface. Okay, anterior surface, while soleal line is located at its posterior surface. Okay, back to the proximal end of tibia. You have lateral condyle, you have medial condyle. Up here you have intercondylar eminences. Okay, eminences. Okay, and down here there is tibial tuberosity. Okay, and this is roughened and perforated area, and then upper posterior you have point of attachment of ligaments that is important to strengthen the knee joint, and finally over the inferior surface of the lateral condyle there is the facet, articular facet for the articulation with the fibula, head of fibula. All right. Okay, this is the view from above. So this is the fibula that articulate with the lateral condyle and inferior part of the lateral condyle, and this is the intracondylar eminence. Okay, or the medial and the lateral eminences, and this is the medial condyle, and this is lateral condyle. This is superior articular surface, and this is the superior articular surface as well, but this is the lateral facet and this is medial facet. And anteriorly, you will have the tibial tuberosity that provide attachment of the patellar ligament. Okay, somewhere at the back here, there is a point of attachment of the ligaments in the knee joint. Okay, this is the intracondylar eminences, medial and lateral. Okay, this is lateral condyle, the medial condyle. This is intercondylar eminences, the lateral one, and this is medial one. And anterior to this eminence, there is anterior intercondylar area and tibial tuberosity at the anterior surface. Okay, what else? Okay, okay. So, well, the shaft of the tibia is extending down from the below this one, the tibial tuberosity, okay, up until the distal end. Okay, this is anterior because there is tibial tuberosity, and this is posterior because there is the soleal line here. Okay, let's go to the anterior first. Okay, this is the interior border of the shaft of the tibia. Okay, for the anterior border, it is actually the part of the leg that can be palpated. Palpated means you will touch it. I can actually touch this directly, the anterior border, because in between bones and the skin there is no muscles, so actually you can actually directly touch this anterior border of the shaft of the tibia. Okay, run to the lateral. Okay, lateral, there is interosseous border. Interosseous border, this one. And what is the importance of interosseous border? It is the point of attachment of the interosseous membrane that connecting the tibia and also fibula. So this is interosseous membrane. And posteriorly, you can actually identify the soleal line here. The soleal line is actually the line that running infero-medially towards the medial side. Okay, it is provide point of muscle attachment, which is the soleus muscle. Okay. Okay, the distal end of the tibia, you can actually identify the medial malleolus. Medial malleolus, okay, this one, and here is the articular face of the medial malleolus that will articulate with the talus here, and this one is inferior articular surface that articulate with the talus of the foot. Okay, and at the lateral side of the distal end there is fibular notch. Fibular notch, that notch that is actually articulate with the distal end of the fibula. Okay, this is the medial malleolus. This is anterior view, the medial malleolus, and here there is a fibular notch. Okay, fibula. This one, fibula. Fibula. Next bone is fibula. This is tibia. You know already. Now it's the fibula. Fibula is the lateral bone of the leg. Okay, it's smaller than tibia. Okay, and obviously, and it proximal end articulates with the what? Do you know? The tibia. Okay, tibia. Where is it? At inferior surface of lateral condyle. And the distal end. It articulates with the talus here and also the tibia at the fibula notch. So this is fibula. Okay, you can actually do this as your exercise. This is for labeling, really good for you. Okay, the surface anatomy is the green shade area is actually located at the lower limb. Okay, this part it can be you can palpate patella at this part, and here lateral condyle, lateral epicondyle, okay, lateral epicondyle, medial epicondyle, lateral condyle, and tibial tuberosity. Okay, anterior border is easily palpated, and medial malleolus, lateral malleolus. Okay. All right, that's all about the tibia and fibula. Now we go to the last part of the free lower limb, which is foot. Okay. Okay. Tarsal. Let's go to the tarsal first. Tarsal is made of 7 bones. Okay. Talus, calcaneus, cubit, cuneiform dia ada 3, lateral, intermediate, and medial, and also navicular bones. Okay, 1, 2, 3, 4, 5, 6, 7. Okay. Where calcaneus, this one, calcaneus is the largest tarsal bone. It forms the heel. Okay, when you walk, your heel, your calcaneus is actually touching the ground. Okay, this is the calcaneus. Calcaneal tuberosity, the posterior roughened area of the calcaneus which contacts the ground during weight bearing. It is the insertion site for the calcaneal Achilles tendon. Down here, back here is actually the side of insertion of the calcaneal tendon or Achilles tendon. Talus is this one. Talus, the only tarsal bone that articulates with the tibia and fibula. Articulation occurs at the superior surface called the trochlea. So this is trochlea. Lateral surface provide point of attachment of the ligaments of ankle joint. Okay, this is the lateral view. So this is the trochlea. So laterally, this is talus and this is calcaneus. Okay. Calcaneus back here, this is the point of attachment, point of attachment of the Achilles tendon. Okay, this one is the other bones, which are the navicular. This is navicular, anterior to the apa nama itu? Anterior to the talus. Okay, anterior to the talus is the navicular. Navicular at the medial side of ankle, articulate to the talus posteriorly, and cuneiform bones anteriorly. Okay. And then you have the cuboid here, articulate with the calcaneus posteriorly and metatarsals distally. And laterally is actually with the cuneiforms and the navicular. Where the cuneiforms, the medial, intermediate, and lateral, they articulate with the navicular posteriorly and metatarsal anteriorly. Lateral cuneiform also articulate with cuboid. Okay. Metatarsus is this one. Okay, this is metatarsus. All right. So of each metatarsus, it's made of head, shaft, and base. Okay. How do you know which one is distal and which one is proximal? Head is proximal. Distal, and base is proximal. Maksudnya, that means okay, head is towards that one. This one is head, and this is base. Okay, base is articulating with the tarsal bone, and the head is pointing out, pointing towards the phalanges. Okay, this is head, and this is base, and this is the shaft of the metatarsus. Okay, the first metatarsal is thicker than the other because it bears more weight and sesamoid bones at the distal end. Actually, the distal end of the, which is the head of the first metatarsal, there are sesamoid bones that is attached at the distal end of it. Okay. Okay, now the phalanges. The phalanges, this one. These are all the phalanges or jari kaki lah, yeah, jari kaki. So this is the big toe. The big toe. There are two phalanges, and then this one is only for big toe. There is a proximal and distal, while the rest with additional middle phalanges. Okay, so this is proximal and distal phalanges of the big toe, and the rest of it, okay, has proximal, middle, and distal phalanges. Okay, arches of the foot. Okay, this is arches of the foot. This is from the medial view. You can see the medial longitudinal arch here, and laterally there is lateral longitudinal arch. Okay, this picture show the medial, and this is lateral longitudinal arches. Okay, this is transverse arch. Okay, arches enable the foot to support the body weight. Okay, this is some clinical importance of the foot. This is normal arch, and the arch is actually up here for normal, but in flat foot deformity, so this is how there is no arch at all. Okay, what are the causes, possible causes of the flat foot deformity? is excessive weight, postural abnormalities, weakened supportive tissue, or genetic. Person with this kind of arch, medial arch, will have problem in long distance walking. Okay, this is also clinical. This is the normal one, and this is the affected of clawfoot. Okay, clawfoot, where the arch is more than normal. Okay, it can easily it is congenital, and in some cases muscle imbalance. For instance, in poliomyelitis, infection of polio. And then I think that's all. This is for you to label, and I wish you all the best in this blog. And this, remember to learn harder in this blog, because this blog involves more memorization of anatomy structure. And after that, I end my session, and thank you for your attention.